Okay, hi everybody. Well, everybody will be hungry, so I'll try to do that very quickly. So this is the clinical pulse, and I just want to present just for the how much immune deficiency, where the the inborn errors immunity is already known, and then how much they are overlapping features, autism or seizures. So, okay. So essentially, the lot of I call inborn errors of immunity, IEI. It's really the people think that's only for the infection or that, but actually a lot of those genes associated with affects the neurodevelopmental issues, also the neuroinflammation, and a lot of overlapping features of the autism, also Pandas type. So as a previous presenters show that the rheumatologic disease, who is really going to show. But this is, I just try to show that some cases I experienced in my clinic. And then those are already well-known underlying baseline immune problems. But it was some of them are mistakenly diagnosed or somewhat diagnosed with autism. Okay. So I'll just try to like a very common one you already know, like a microdeletion syndrome, Dijol syndrome, and Kabuki is actually not a microdeletion, but it's Dijol Kabuki syndrome charge association, very kind of overlapping feature Dijol syndrome. Then also chromosome abnormality, trisomy 21. Actually, that has a lot of immune problem. Then auto-inflammatory syndrome, FMF, CAPS, PR3K delta syndrome, interferonopathies. Those are all auto-inflammatory syndrome. So, yeah. And those auto-inflammatory syndrome patients that, I think how to do the screen, full screen? Yeah. Big screen? Yeah. Either way it's fine. Yeah. Yeah. Okay. Thank you. Yeah. So essentially, I will just do because everybody is tired and also maybe hungry. So I will just do presenting the clinical cases. So Dijol syndrome is really for the 22q11.2, typically 3.2 kilobase deletion. And there is now the clinic, the good understanding why this region is deleted. However, I think it's, and its end result is a mild, often mild tyrosine. But also there is a lot of, especially when it's getting older, schizophrenia, ASD, and all the seizure, and a lot of neuropsych symptoms kicks in. Okay, so those are like Dijol syndrome patient. And it's really the risk of the ASD is a fourfold. And some of the patients I have older, like a young adult, actually the parents are very frustrated because they grow and they overcome the infection, but they are presenting a lot of neuropsych symptoms. So this is okay, so sorry. Thanks. Okay, I'm sorry. I'm sorry. This is a patient I have tried to presenting, and this is really when he came here 8 years old, and actually he was diagnosed with ASD after 2 years of age, very nonverbal. But actually with somehow neurology ordered for microarray. And that was really that he was found to have the 22q11.2, really classical 3.2 kilobase deletion. And this patient was already giving the very high dose of risperidone, and I'm glad that one neurologist told the risperidone more than 2 years. He was really giving the very, very high dose because of very difficult behaviors, and he gained the weight a lot and hypogammaglobulinemia. And this is a patient I have really struggled to give the supplemental immunoglobulin because his behavior is so difficult. I have to ask the anesthesiologist to do the general anesthesia each time, then try to reduce the risperidone. And so actually for the, this patient is really for the, gradually gets better. And this patient is actually, I was able to offer the IVIG because they are able to reduce the risperidone when infection is under control. Then he, actually immunoglobulin level is increased. So now he's doing okay. And with just for the supplemental prophylaxis antibiotics and for the other dietary supplement. And these patients also depends on the microdeletion part. There is a lot of problem of the microRNA control and also oxidative stress. So that's why we have to give a lot of different type of the supplement. Okay, I'm sorry about. And Down syndrome patient, I'll just quickly say Down syndrome patient. This patient is again, he was doing okay, but then suddenly started having the a catatonia type anxiety OCD, which is started around 15 years of age. And he was really for the try to do a lot of neurological workup, but essentially they somehow tried on the PANS workup, but essentially this Down syndrome patient is well known to have the humoral immunity. It's declining with age. And those patients is actually what I did is just to do the humoral immune workup. Then he didn't have any pneumococcal antibodies. So essentially we started in the IVIG and he did very well. And his catatonia symptoms actually gradually resolved. So essentially, the Down syndrome patient, everybody thinks that's just a developmental delay. Actually, there is a good reason to have the humoral immune deficiency. And this is partly gene dosage effect of the TCR and FAT5, but also depends on the condition, but it's a lot of oxidative stress. So actually metabolism, humoral immunity, and developmental. So it's a very complex condition. Okay. And this is a Kabuki syndrome patient. This patient, I couldn't believe that because again, this patient was diagnosed before 2 years of age, remained nonverbal, starting seizures. But he has a classical facial features of the Kabuki syndrome. It's really, Kabuki is makeup like. So I wasn't sure why it was missed, but actually the mom suspected that was the Kabuki syndrome. So actually she contacted Johns Hopkins. So he was diagnosed with Kabuki syndrome. And the patient was tried on the high dose of the IVIG before the diagnosis, and he was really did terrible. He was really get worse, and this was actually expected for this type of the patient, and because the Kabuki syndrome is usually diagnosed with very impaired humoral immunity, and so we have to switch to sub-Q and low dose, and he did great for the little while, and seizure under control. However, unfortunately, he got COVID-19. And T-cell impaired immune system, it's really susceptible to severe COVID-19. And he, unfortunately, he's right now struggling with long COVID syndrome. Colchicine provides some, and actually he was treated when in hospital, remdesivir and baristonib, but still he's not completely recovered yet. Okay. And so essentially, Kabuki syndrome, I just guess that he did have the classical KMT2D pathologic variant, and these patients, obviously, this is a histone transferase deficiency, and so the downstream genes are a lot affected. So that's the reason why the end result is metabolic changes. Yeah, I tried to as quickly as possible. And then I'm just going to very quickly to the autoinflammatory syndrome affecting inflammasome 14 years old. Because this is a patient is really for the we couldn't really find out the genes, but he was also treated with like PANS, PANDAS, and then also severe behavioral symptoms. And actually, he was 14 years old, but he was suspected, or a neurologist thought he has like a late onset ASD or mild ASD. And unfortunately, this one didn't really find out any kind of the genetic or pathological variant. However, clinical studies really classical CAPS-like condition. CAPS is cryopyrin-associated periodic fever syndrome. So this patient, what I did is really starting with colchicine, because colchicine is like blocking the inflammasome. So it's one of the like a CAPS treatment. Then this one, and then add the anakinra. And part of the reason is anakinra is IL-1 beta blocker, but it's very painful for the injection site. And this patient was diagnosed with small fiber neuropathy. So it's really very painful, very sensitive to pain. So that's the reason why I colchicine, hoping to reducing inflammation. Then started the anakinra by using the local anesthesia. And actually he's doing fine, because beforehand he refused to come out from the room. And he really kind of is very difficult behavior. Now he can go out and get outside, and he started going out. And it's really a matter of the 1 or 2 months. So sometimes these like a very like a convincing data, those specific treatment may work. I don't think he looks like autism patient anymore. Okay. And so, and another one is like a type 1 interferonopathies. And this is like a type 1 interferon overproduction. And this is multiple genes are involved. And the type 1 interferon, I wanted to talk because type 1 interferon overproduction, its clinical features really dramatic, very affecting the neuropsych, brain and other the nervous system. So essentially the psychomotor retardation, seizure, encephalopathy. So these type of the condition, and one of the like prototype, it's one of the prototype is really actually very well known to have the like a classical lupus type symptoms. Okay. And this is a patient I have experiment is autoinflammatory syndrome is a COPA syndrome. And COPA genes are both like 2 siblings are presented. Then actually 1 sibling was diagnosed ASD type 1. And so this is severe anxiety, but some, and these type of the increasing the type 1 interferon alpha actually promoting the autoantibody production, and sometimes very difficult to control. And IVIG, steroid, regular autoimmune medications, essentially, and also the blockers, the inflammasomes have been used. However, these type 1 interferonopathy patients, it's very difficult to control. And actually, we are still struggling. We used some IVIG, some steroid, sirolimus, and also now getting into the Rinvoq, one of the new JAK1/2 inhibitor. It's best to respond to the JAK1/2 inhibitors, but still it's not perfect. So, and he was there beforehand. They tried so many different SSRIs or other they did terrible, all these medications. So this is just for the Cooper syndrome, and essentially these patients, they don't do well with IVIG. Okay. So I just tried to do very quickly, I'm sorry. So this is just for the lot of already gene-specific condition, like a gene mutation already well identified. But it's so amazing to see that so many those inborn errors causing the immune system problem, also causing the neuroinflammatory type condition. So it's just to get some idea how the immune system and nervous system are interrelated, then why I'm interested in the neuroinflammation.